So I'm going to talk on causes and management of hyperkalemia and hyponatremia. So to start with hyperkalemia, we all know hyperkalemia definition is serum potassium level of more than 5.5 milliequivalent per liter. We'll jump to the causes of hyperkalemia. It is broadly divided into 4 causes. First is pseudo hyperkalemia. So that is not actual rise in potassium. It is artificial increase in potassium due to venipuncture or tight clenching of the feast. Then there is cellular efflux in case of increased cell number seen in thrombocytosis, erythrocytosis, and leukocytosis, and in hemolysis. Then there is increased intake of potassium seen with potassium supplements, and nowadays lots of people are using this salt substitutes. They are not using sodium, but they are using potassium salt. That is also one of the cause of hyperkalemia. Next cause is transcellular shift from intracellular to extracellular shift seen in case of acidosis, hyperosmolality, in case of high sugar levels, patients using beta-2 adrenergic antagonist, digoxin, and rapid tumor lysis syndrome and rhabdomyolysis. Most common causes inadequate renal excretion of potassium from the body. It is subdivided into following causes: inhibition of the renin, angiotensin, aldosterone axis seen in many drugs like ACE inhibitors, renin inhibitors, angiotensin receptor blockers, mineralocorticoid receptor blockers, and epithelial channel blockers. Then it could be due to decreased distal renal flow seen in congestive heart failure and volume depletion states. Next is decreased renin state, which is seen in tubulointerstitial diseases and diabetes and drugs like NSAIDs. Next cause is renal resistance to mineralocorticoid. The mineralocorticoid level are normal, but there is renal resistance, which is again seen in tubulointerstitial diseases like SLE, sickle cell anemia, obstructive uropathy, and certain hereditary causes. Then there is primary adrenal insufficiency, seen in autoimmune infectious and infiltrative disease and advanced renal insufficiency. These are the causes of hyperkalemia. So the most important thing is history and thorough physical examination. We have to look for blood pressure and fluid status, urine output, review the potassium intake and the drug list of the patient, review the history for the causes of renal disease, and review the recent biochemical results. From that, we'll be able to know whether this is acute or chronic hyperkalemia. This is a chart showing diagnostic approach for hyperkalemia. So hyperkalemia could be, first we have to rule out whether it is pseudo or a true hyperkalemia. So we rule out the causes like hemolysis and thrombocytosis, leukocytosis. Then we go to the causes which causes redistribution. So those are acidosis, diabetic ketoacidosis, beta blockers, digoxin toxicity. And next, then it is true hyperkalemia. So as per the history, we'll be able to know whether the patient is having increased intake and increased tissue release of potassium, or the hyperkalemia is due to decreased excretion from the kidneys. So if it is the renal cause, we look at the RFT, and if the GFR is less than 20, then it could be acute or chronic kidney disease. And if the GFR is more than 20, we have to differentiate whether it is aldosterone related or not dependent on aldosterone. So we have to look for the aldosterone and renin levels, and accordingly we'll be able to know whether it is related to Addison's disease or hereditary causes or drugs like heparin, NSAIDs, ACE inhibitors, cyclosporin. So there are other tubular hyperkalemia causes which are not aldosterone deficiency dependent. They are acquired causes like obstruction, renal transplant, SLE, amyloidosis, and sickle cell disease. So the treatment strategy, it is a stepwise approach. First we have to protect the heart and shift the potassium intracellularly, remove the potassium from the body, regular monitoring of potassium and glucose has to be done, and prevent the recurrence. So these are the modalities for the treatment. The membrane stabilizers, we all know it is calcium gluconate. The shifters are insulin plus glucose and beta-2 agonist. The excretors, it can be excreted from urine by using furosemide. We can use sodium bicarbonate in patients who are having acidosis and hyperkalemia. Then fecal excretion is by sodium or calcium polystyrene sulfonate, that is the potassium binders. And definitive treatment is hemodialysis. So this is the treatment approach for hyperkalemia. First, we have to see whether it is acute or chronic hyperkalemia. In acute cases, we have to immediately go for the treatment in the form of IV calcium, insulin glucose, nebulized salbutamol. followed by IV sodium bicarbonate in patients having acidosis, diuretics in patients who are having fluid overload, and hemodialysis in patients with renal failure. And if the patients are, if it is a chronic hyperkalemia, which we frequently seen in our OPD setting, patients having around 5.56 potassium. So first and foremost, we have to do a dietary potassium counseling, and we have to manage the RAS inhibitor therapies. We don't have to just stop it. We have to either stop it transiently or decrease the dose and then reinitiate it. We have to give a effective diuretic therapy, oral sodium bicarbonate, again if there is acidosis, and give potassium binders. And we have to keep on monitoring the potassium at least 2 to 3 times a year. We have to review the medication list. We have to see whether they are taking herbal supplements which increase the potassium levels and create awareness. So this hyperkalemia can lead to adverse cardiac outcome and mortality. Regular screening for early detection is warranted, and management of hyperkalemia is multifaceted, includes both acute as well as chronic management. So the decision regarding keeping the patient on RAS inhibitors and accepting hyperkalemia versus whether we should stop the RAS inhibitors, then the patients will be deprived of the renal and cardioprotective benefits of those drugs. So it is still a gray area and the decision has to be individualized. So now we go to hyponatremia, which is defined as a serum sodium concentration of less than 135 milliequivalent per liter. So hyponatremia is mainly a disorder of water regulation and not sodium regulation. It is relative excess of water in relation to sodium. These are the types of hyponatremia: redistributive pseudo-hyponatremia, and the rest are the true hyponatremia. So what is redistributive hyponatremia? In that the water shifts from the intra to extracellular compartment, and so there is dilution of sodium in the extracellular compartment. So in that the total body water and the sodium, they remain same, unchanged. So it is seen in hyperglycemia in patients who have been administered mannitol, like in hyperosmolar states. Next is pseudo-hyponatremia. It is not a true hyponatremia. It is a laboratory artifact basically. It is seen in patients with hypertriglyceridemia and multiple myeloma. So next.
What was that figure? What is that? The figure? The figure.
So they are triglyceride. In triglyceride, hypertriglyceridemia in patients having obesity and metabolic syndrome type of patient. So next is, so after ruling out those two causes, we come to true hyponatremia. That is hypotonic hyponatremia. It is divided as per the volume status of the patient into hypovolemic, euvolemic, and hypervolemic. Hypovolemic is due to decrease in the volume. It could be due to renal loss or extra renal loss. Renal losses are due to diuretic excess, mineralocorticoid deficiency, salt losing nephropathy, osmotic diuresis, and the extra renal losses are due to vomiting, diarrhea, and third spacing of fluids. This is the most commonly encountered group of patients seen in the hospital, euvolemic hyponatremia. The causes are glucocorticoid deficiency, hypothyroidism, stress, drugs like antipsychotics, SSRI, and the SIADH. Next is hypervolemic hyponatremia. It could be renal in origin, seen in acute or chronic kidney disease, or related to cirrhosis, cardiac failure, and nephrotic syndrome, in which there is decreased effective arterial volume. So this is the most common type of hyponatremia we see in hospitals, and there is a long list of the causes of SIADH seen in neoplastic conditions, pulmonary infections, asthma, CNS infections, bleeding, tumors, trauma, and drugs like AVP analogs, and the drugs that stimulate the ADH secretion or action, that is SSRI, antipsychotics, antiepileptics. This is the diagnostic criteria for SIADH. So we have to look for this essential diagnostic criteria. The serum osmolality should be less than 270 milliosmol per kg of water. Urinary osmolality should be more than 100. Clinically, patient should be euvolemic. Elevated urinary sodium should be there. And this is most important thing. There should be absence of adrenal, thyroid, pituitary, or renal insufficiency or diuretic use. So this is diagnosis of exclusion. For the diagnosis of hyponatremia, mainly we need 4 tests: serum sodium, serum osmolality, urinary sodium, and urinary osmolality. First, we have to look for serum osmolality. If the normal range is 275 to 290, so if it is a hyperosmolar state, then the causes are hyperglycemia or administration of mannitol. If the osmolality is in the normal range between 275 to 290, it is hyperlipidemia or hyperproteinemia. And if it is hypotonic, the osmolality is less, then it is true hyponatremia, and it is divided as per the volume status, as we have seen in the previous slides. Patients having hypervolemia, euvolemia, and hypovolemia. So we have to look for the volume status. So we see in the patient the pulse and the blood pressure, and if there is any signs of fluid overload like edema, then in examination, respiratory examination, crepitations are there. The urinary, next is urinary osmolality. So normal value is more than 100 milliosmol per kg. If the osmolality is less than 100, then there are very few causes. So it is almost, there is extra water in the body. That is primary polydipsia, excessive water ingestion, excessive take water in infants, it is seen. And if the osmolality is more, then all other causes, like SIDH, diuretics, hyperglycemia, they have more than 100 milliosmol per kg urinary osmolality. So in this, less than 100 milliosmolality is important because very few causes are there. Next is urinary sodium. If the urinary sodium is more than 20, it indicates SIDH, diuretics, and other hormonal causes like thyroid, hypothyroidism, then adrenal deficiency, glucocorticoid deficiency basically. And if the urinary sodium is less than 20, then it could be the causes which have causes volume depletion, basically GI loss, skin loss, third spacing, and the causes which have low effective arterial volume like cirrhosis, nephrotic syndrome, congestive heart failure. So this is kind of simplified version of what I have said. We have to look for, first we have seen serum osmolality and decided that this is true hyponatremia because the serum osmolality is less than 275. Then we look for urinary sodium and urinary osmolality. So if both the things are low, then mainly it is primary primary polydipsia and beer drinkers hyponatremia, low solute intake, and water diuresis during treatment of hyponatremia. If this urinary sodium is low and urinary osmolality is high, this urinary sodium is low, that means the effective volume is less. So it is seen in patients with hypovolemia and conditions having low effective arterial volume. And if both the things are high, then mainly it is due to active use of diuretics, SIDH, and all the causes of euvolemia, like due to adrenal insufficiency. In hypothyroidism also it is seen, in CKD also it is seen. So this is the treatment approach. When the patient comes to us, we have to see whether patient is symptomatic or asymptomatic and whether it is acute or chronic. If the patient is symptomatic and it is acute duration, then we have to give emergency correction in the form of hypertonic saline at the rate of 1 to 2 ml per kg per hour, along with the co-administration of furosemide. Previously, various formulas were being used, but now the guidelines say we have to straight away give it and closely monitor the sodium levels. In patients who are symptomatic and have chronic duration of hyponatremia, so initially we have to give immediate correction in the form of hypertonic saline and co-administration of furosemide, and then change to water restriction upon 10% increase of the sodium levels or once the symptoms resolve. And we have to frequently measure the serum and urinary electrolytes, and the target for sodium correction should not be more than 10 to 12 millimole per liter per day. Otherwise, it may cause osmotic demyelination, which is a very fatal condition. In asymptomatic patients who are chronic, no immediate action is required. Long-term management in the form of identification and treatment of reversible causes is done. Water restriction has to be advised. And majorly we use this V2 receptor antagonist, that is tolvaptan, in the dose of 15 to 60 milligram per day. It is mainly used in cases of euvolemic hyponatremia and hypervolemic hyponatremia, in which there is increased ADH in the body. So for hyponatremia, the approach is to do the basic 4 test, and we have to see the pattern of urinary sodium and urinary osmolality and decide for the diagnosis and treat accordingly. We have to treat the symptomatic patients rapidly, and correction should not be more than 10 to 12 milliequivalent per liter per day. Thank you.